Hello, everybody, and welcome to the Department of Psychiatry Grand Rounds. So today we have got Dr. Masha Calic, who's going to present Disengagement from Mental Health Services, a closer look at gender. So for people who don't know Masha, she is one of our wonderful residents, a PGY 4 year now, and she's originally from Toronto, did her undergraduate BSc Psychology at York University, and then she went abroad for medical school to St. George's University. And she then was also on placements in Newcastle in England, Brooklyn in New York in America, and also in Grenada for her clinical rotations, and then matched for psychiatry at Queen's University. She tells me that her academic interests are in child and adolescent psychiatry and also first episode psychosis. She likes working in team settings, imagines herself combining inpatient, outpatient work in the future as a psychiatrist, and outside of work enjoys spending time with her son, family, friends, and staying active. So without further ado, we will move on to Dr. Calic's presentation. Thank you.
Thank you, Dr. Chu. So I guess I don't have to introduce myself. But yeah, my name is Masha. I'm a PGY 4 resident, and the title of my grand rounds is Disengagement from Mental Health Services with a closer look at gender. And this was supervised by Dr. Roberge. So just to go over the learning objectives again, hopefully by the end of this presentation, the audience will be able to define what engagement is, disengagement, understand clinical implications of disengaging from mental health services. They'll be able to review factors that predict disengagement with a closer look at the role of gender in disengagement research, and hopefully the audience will be able to appreciate facilitators and barriers of engagement, which can maybe help in practice too. So I just want to start off with a quote. Any intervention is only as effective as the willingness of those who need it choosing to engage with it. So what is engagement? I guess a lot of different things can come to mind. So I just wrote a few here. It's adherence to treatment, remaining in contact with services, collaborating with the treatment team, being open about difficulties in treatment, and forming a trusting relationship between the patient and the treatment team. Just to kind of expand on this definition, so engagement is really a dynamic process. So there's not one definition for engagement, but it involves different elements. So for example, you have to have the acceptance of the need for help. You have to form a therapeutic alliance. You must work with your team or with your provider towards shared goals, and there must be satisfaction with the help that is received. Engagement must happen before a client or a patient can actually move into an active phase of treatment. And it's also important to note that attendance doesn't equal engagement. And this is because some people might be coming to services or seeing a clinician because they're pressured from their family. They might have legal obligations to do so, but they may be ambivalent or antagonistic towards the services. And we see that a lot. On the other hand, there may be individuals that really want to engage, but because of other commitments in life or distances to services, lack of access, they may not be able to engage or attend for that matter. So moving to the other side of the spectrum, what is disengagement? So disengagement, just like engagement, has many different definitions, but it consists of no contact with the treatment team, active refusal of being part of the treatment, failure to re-engage the patient after several attempts, and all of these lead to termination of treatment despite the therapeutic need for treatment and despite the clinical advice. There's been inconsistent definition across literature when it comes to disengagement. What I found most consistently is many studies define disengagement as not having contact with a treatment team for 3 or more consecutive months before the completion of treatment and after all possible ways to engage the patient have been explored. It's also important to remember that if a patient doesn't attend for a specific period of time and that time is equal to disengagement, then that time must reflect their need for treatment. Another important point is that disengagement is not absolute. So a lot of patients can re-engage. So it's just important to remember that it's not a terminal thing. In regards to disengagement research, most of the research is in early psychosis intervention, and that's because this group is at high risk, as I will mention in my next slide. The studies follow patients in differing lengths of time. So generally 9 months is sort of the shortest follow-up, and then it can go as long as 3 years, which is usually how long these first episode psychosis interventions last. Across literature, the rates of disengagement for mental health services have been roughly around 30%. So studies can range from anywhere from 12% to like 50%, but really kind of the average is about a third of patients will disengage from mental health services. It's also important to remember that in a lot of these studies, they may not differentiate between the people who drop out because they don't want the treatment anymore versus those that may relocate to different services. They may move out of the country, they may die, or they may have a positive disengagement, which is a decision made with their treatment team to disengage or to terminate treatment. So the definition really makes it kind of difficult to come up with clear, conclusions from the research. Who is at risk of disengaging? Really, it's anybody who is transitioning from different levels of care. So as we know, like post-ER discharge or post-hospital admission, that's the critical part when someone's at high risk of disengagement. Also, when starting a service or service initiation, research has shown that the first appointment is the most frequently not attended appointment. So I think the range there's ranges from 18 to 67% of people who don't actually come to their first outpatient appointment. And as I mentioned in the previous slide, a lot of the research and what I'm going to talk about today is going to focus a lot on first episode psychosis. The reason being is that first episode psychosis occurs in late adolescent and early adulthood, and this population is in and of itself at high risk of disengagement. It's also important to study this population because the first 2 years following a diagnosis of first episode psychosis are important in establishing the trajectory of this patient's outcome as well. This is a little bit of a theory to go with this presentation, so theoretical model. It's called the Anderson model of healthcare utilization. And it really identifies factors that may facilitate or hinder access to services or for someone to actually go and obtain services. So there's 3 different factors that that Anderson kind of talks about that influence a choice to engage. And that could be predisposing factors, enabling factors, and need factors. So predisposing factors are social and demographic characteristics of an individual that exist prior to their illness, and it reflects the individual's propensity to use health services. So that can be things like their gender, their ethnicity, their education level. Enabling factors are logistic aspects of obtaining care, and they include both personal, familial, and community level features that exist that may affect the way a person uses healthcare resources. So it could be things like finances and whether someone has access to resources. It could be family support. It could be their diagnosis, which then enables them to get treatment or engage in services. Things like stigma can be enabling or disenabling in most cases. Need factors are either you have a perceived need, which is the individual's perceived need that they actually need a health service, as well as the evaluated need, so based on professional assessments. And these are things like if someone has the severity of their illness at baseline, their drug use, how their level of functioning is, or whether they're suicidal or at risk of self-harm. So all of these factors work together to then influence disengagement with which influences health outcomes in the long run. Oh, sorry. So why are we talking about this today? Because disengagement can lead to increase in relapse rates. It can lead to increased hospitalizations. People who disengage have lower vocational, interpersonal, and social functioning. It can lead to homelessness and incarceration, and disengagement can also lead to increase in mortality and suicide rates, which have all been reported in research. I'm going to move on to talk about factors that affect disengagement. So the literature lists a lot of different factors, but the three that kind of are most robust predictors of disengagement are the three that I listed here. So medication non-adherence, lack of family involvement, and substance use. So medication non-adherence is like an umbrella term for many different things, but basically medication non-adherence is it's defined differently in research. So sometimes it could be any mention of med non-adherence. Sometimes it could be the patient is adherent if they're taking their medication 75% of the time or more. But we know that this is largely influenced by side effects, lack of psychoeducation, poor therapeutic alliance, poor insight. And as we know, patients who are non-compliant with their medication have a worsening in their clinical state, and then that leads to them more likely disengaging, which is pretty self-explanatory. Lack of family involvement as well. So research has found that family support is related to a decrease in relapse rates, decrease in hospitalization, increased medication adherence, better social and vocational functioning, just generally a better quality of life. And the reason probably is because caregivers also have a practical role in engagement by taking the person to their appointments, encouraging participation, helping them with their medications. It's also important to note that obviously not all families have a positive impact on engagement, and some families can be critical, hostile towards the provider. There could be a lot of interpersonal difficulties in the family, but generally speaking, family involvement leads to better engagement. And then the last one is substance use. So as we know, substance use is related to worse functioning, lower insight, patients who have more hospitalizations. So really, it's kind of a self-explanatory one in regards to how it may influence non-adherence and disengagement. So I want to talk about more factors that we may think about when we're discussing disengagement. So there's a lot of between study variation in other factors, but I'll still go through them. So there's been mixed findings on age, for example. I think most people will kind of have this view that younger males may disengage more, and generally younger people may disengage because they have more doubt, they have these negative stereotypes of mental illness, poor insight. This has been mixed in literature, so sometimes it's not always that younger people. Sometimes it could be older people too that are at higher risk. In regards to ethnic minorities, it has been found in some studies that patients of ethnic minorities are more likely to terminate treatment prematurely. And usually this is related to the fact that ethnic minority individuals are more likely to be detained under the Mental Health Act. They have more coercive hospital treatment. They're less satisfied with services, and they tend to be overrepresented in the forensic system. But again, these studies haven't been replicated in enough studies for it to be a robust predictor. Illness at baseline. So that is made up of many different things. It could be severity of illness. So when we think about someone who's doing worse and their higher severity of illness, we sometimes think that it's hard to engage them, right? But that may not always be the case. They may be more engaged because of their family support. So that really varies. Also, the duration of untreated psychosis has inconsistently been tied to disengagement. In regards to affective and non-affective psychosis, so affective psychosis being bipolar disorder, schizoaffective, major depressive with psychosis. These diagnoses, as we know, tend to have a better prognosis, and they actually have been tied to higher rates of engagement. So patients who have affective psychosis generally tend to engage more than those that have non-affective. But again, it hasn't been a robust finding. Employment and education level also vary. So sometimes patients who have lower education levels may be more likely to disengage, but sometimes they might be more likely to engage because they don't have the commitment of school and work. Homelessness generally is tied to disengagement, and that's primarily because patients who are homeless are going to go to an inpatient setting or an emergency much more than actually attend outpatient services. And then forensic history has also been found to be related to disengagement. And those with a forensic history are twice as likely to disengage in some studies. This is related to their social deprivation, maybe related to antisocial traits of impulsivity, difficulties with compliance. So now I want to talk about the gender that I mentioned in the beginning. So gender is an inconsistent predictor of disengagement. So some studies have found that being a male is a risk factor, but again, it's not consistent across literature. Generally, males do tend to attend less or fewer sessions. They drop out from treatment prematurely, and they're less likely to access help. This has been shown in some studies. Because I was talking about first episode psychosis, I just wanted to highlight some of the differences between males and females because these may relate to their engagement rates. So males generally in literature, it's been found that they have worse premorbid functioning, they have more substance use, they have more negative symptoms, more legal involvement, their social functioning is worse, and culturally the help seeking is in conflict with their internalized male role. So the help seeking is kind of equivalent to being weak, to being vulnerable, or like embarrassed, and then that can kind of clash with the internalized male role. In females, generally speaking, they have a higher premorbid function, and this may also be related to the fact that females tend to get first episode psychosis at a later age than males. They have less comorbid use. They have more affective symptoms, as we talked about, which could have a better prognosis. They have better compliance in general, better insight, and culturally speaking, they've been found to be more adaptive and conform, have more conformity in general. So I'm going to talk about the research that I did in this topic and the reason why I chose to present on this topic. So Dr. Roberge did connect me with a researcher, Dr. Kozlov at CAMH, and her research looks at disengagement from early psychosis intervention services. They look at the population in Toronto who accesses the service through CAMH. But my interest was looking at gender and service engagement in early psychosis intervention. And the work that I did was a sub-analysis of this bigger study, which was published. So I'm going to talk about the work that they did, and then I did my sub-analysis based on that. But the first part of this study involved a chart review of 225 patients, and majority of them were male, so 155 male. They ranged in ages from 16 to 29 to qualify for this service. The average age was about 22. More than half were unemployed, and there was quite high family involvement, and again, quite high substance use. About half of them used substances. To be part of this part of the study, they had to have attended at least one follow-up appointment with the first episode psychosis program. And the dependent variable, or the outcome that we were interested in, was looking at early disengagement. So early being the first 9 months since the initiation of services. What my sub-analysis found, my study found, was that disengagement rates were similar across gender. And I didn't mention my hypothesis, but my hypothesis based on the premorbid functioning and the features of males and females. The difference was that males would have a higher disengagement rate, but in fact, they were not significantly different, even though females are a little bit higher. The other downside is that we also had a lot more males in the sample size as well. What I did find, though, which was interesting, was that each gender had different factors that were associated with disengagement. So for males, we found a significant, statistically significant relationship between legal involvement and disengagement. So those that are more involved in the forensic system are more likely to disengage, which we talked about, and we kind of understand why that may be. The other one was that males who didn't attend appointments are more likely to disengage. So again, appointment non-adherence can sort of represent a general non-adherence to services. And in the study, the limitation was that they defined non-adherence as missing one appointment. So like that's not really a great representation, but anyways, this was found to be significant. An interesting finding was that females who are less active in school or work, so have less vocational activity, they're less likely to disengage. And what this kind of makes us think about is that those who are more likely to be in school or at work could be better functioning to begin with. They may not need the services, or they may not have the time. So I think it means that disengagement is not always a bad thing, because it might represent that these people are actually higher functioning. We also found that females with non-affective psychosis, so the kind of psychosis such as schizophrenia, brief psychotic disorder, or schizophreniform, they're more likely to disengage. And this is a busier slide of the table with the factors that we looked at. So we didn't look at, I was limited to the number of factors I could look at because of the sample size. So these are the ones we looked at, and then I highlighted the ones that were significant in females and males across gender. So next I want to talk about facilitators and barriers of engagement. So I think we're moving on to a bit more practical things. One thing is looking at what factors can predict disengagement, but then the other thing is actually going in and asking patients, families, and providers, what are facilitators and what are barriers of engaging in services? And a lot of these findings are from surveys and interviews. And sort of the themes that I wanted to highlight that could either be a facilitator or a barrier are things like therapeutic relationship. That's really an important one. So whether there's a good alliance, the attitude that the patient has towards their therapist, the trust that they have in them. Then we have things like how professional is the provider and the environment, how competent they are they authentic and genuine towards the patient? Patient autonomy is a really big deal. So are we looking at the patient's perspective and allowing them to take part in the decision-making process? Personal and independent, personal and independent attributes. So that is mostly related to like one's belief, whether they're ill, one's insight, the severity of their illness. Family involvement and family influence can again be either a hindrance or a facilitator. Then we have program attributes and practical challenges. So things like, are there cultural or language barriers, the location, is there consistency within the care provided? And then medications can also be a huge barrier because of side effects. And sometimes they could be a facilitator, obviously, if they're helping the patient with their symptoms. So another busier slide. The reason why is because I think this is important for us to consider. So I divided the different barriers into either related to the individual level, the provider level, or the program level. So based on the research, these are the common barriers that patients have listed. So they, as an on the individual level, they found distressing experiences in the past and traumatic hospitalizations as a barrier to engage currently. They found that treatment was not necessary for them. They might not need the treatment. It did not meet their needs. They may have a desire to treat their condition without services. Patients may have an unstable living environment. They may have a poor support system. Other factors could be their symptom severity, cognitive impairment, low motivation, substance use, poor insight, some of what we talked about. Forgetting appointments is a big one for them. Being uncomfortable leaving the house and going to an unfamiliar place. disliking, and then going to the provider attributes, so disliking or not trusting the clinician, inconsistencies between what the patient needs and what the treatment plan is, lack of psychoeducation provided to the patient, and then program or systemic attributes include rejections in attempts to obtain help previously. So that's what the patient themselves have reported. Lack of continuity with providers, the duration or the intensity of services may be a barrier, location, access to transportation, and availability of support, more so in like a 24-hour, like outside of work hours. The other two important ones are stigma and medication side effects as a barrier. And I put these at the bottom because I feel like they may sort of fall into any of these three categories. So going back to the gender study that I did, the second part of the study was looking at survey results, which obtained patient-reported facilitators and barriers of engaging in services. So this did not have to be this. It wasn't necessarily the same population or of people as in the first part of the study. There were 167 participants, and this time there was an equal number of females and males. So about 75 of each. Also 13 individuals identified as other gender or gender variant. So we actually spoke to these individuals and they wanted to be referred at as gender variant. They identified as either trans, non-binary, two-spirit, or don't know. And again, the age group was 16 to 29. Average age was the same as the previous study, which was 22. I think, I just want to mention that they didn't actually have to participate in the services, so they might have not even gone to their first appointment as opposed to the first part of the study. So what we found in regards to facilitators of engagement, so these 6 that I listed here are sort of the top ones that were rated, and there was a long list of like probably 20 to 30 different reasons for facilitating or that may facilitate engagement. And the ones we found that were sort of the top facilitators were the patient's own motivation. So my own motivation and commitment to treatment, you can tell that across all genders is pretty high. Other ones were my clinician explained the rationale and reasons for service. I believe my clinician had an understanding of what my experience have meant to me. That one's also important. My clinician and I agree on what is important for me to work on. My clinician speaks to me about my personal goals and thoughts about treatment, another like top and high one, and the location of services may have been a facilitator for these people. So really the takeaway from this, because I know it's a bit busier, but is that the patient's own motivation for treatment and their communication with the clinician about treatment goals really stood out as the main facilitators of engagement. Looking at the barriers of barriers to engagement. The main one, the top one here is I feel uncomfortable leaving my house or going to an unfamiliar place. So the gender variant group marked this as a high barrier. Being bothered by medication side effects was a top one for all genders. Past negative experiences with services. It is uncomfortable when I disagree with my clinician or haven't followed the treatment plan. So the gender variant marked that as higher. Forgetting or losing track, forgetting appointments, not liking coming to hospital, and the location of services can be a barrier to some. So I think the takeaway from this slide is that medication side effects are a top-rated barrier, as well as forgetting appointments and losing track of time. And for the gender variant group, I think it's important to note that they marked feeling uncomfortable leaving their house and feeling uncomfortable when they disagree with the clinician as well. So that's kind of something to keep in mind. So the discussion or sort of the takeaway from the study that I did or the research that I did is that is to highlight the importance of the therapeutic relationship, the importance of self-motivation and the location of services, to keep in mind that the most common barrier is medication side effects. And as we heard, as I mentioned in the beginning, medication non-adherence strongly predicts service disengagement. It's also important to keep in mind this gender variant group and that they may understandably feel more uncomfortable with just even coming and engaging and talking about goals. So I think we need increased support and validation of this group. I think we also need more research with a gender variant group with a higher population, because ours was only 13 individuals. And I think the other thing to keep in mind is that there's different factors that affect disengagement in males and females. And I think more studies need to be done, because then we can react differently to them based on what is driving the disengagement. So how do we increase engagement? There's a few points here that I want to mention. So service providers, I think, should be trained in assessing engagement, so kind of understanding what the different elements of engagement are, and they should identify barriers and maybe have open conversations with the patient as well. I think clinicians should identify needs and actively engage patients early in engagement. So as I said, the initial part is really the crucial part, and that's where it's the highest risk for disengagement. I also want to mention that the timing of when someone disengages can also shed light on why they're disengaging. So if someone disengages right at the beginning, it could be because of their beliefs, and their stigma, and it could be because of the severity of their symptoms. While later on, once treatment has already started, later on, if someone disengages, usually that's related to the lack of therapeutic alliance or the lack of satisfaction with the service that is received. So I think it's important to keep in mind like when they're disengaging and why. So it's important to have a positive initial contact, to have a caring and non-critical environment, to help the patient feel understood, listened to kind of ensure personal connectedness, agreeing on a treatment plan, discussing personal goals, and involving family whenever possible. So as like in the sample that I studied, a lot of the family was already engaged, and our disengagement rate was about 18%, 17-18%, which is lower than that 30%. So I wonder if that's because the families were involved in their care. And sometimes family can be a hindrance, as I said, so kind of helping navigate the relationship with families and helping them set boundaries when needed. So some practical suggestions for change that could increase disengagement. So providing, because patients, said they may forget appointments, or, there may be the appointment times or locations. So providing appointments during evenings or weekends. I know that's obviously not feasible for many people. Sending appointment reminders, which I know we often do in the outpatient setting. Communicating with text or email could be another idea, or offering appointments in the community. I'm going to mention, I realized I didn't talk about virtual disengagement, and I looked it up. Most of the studies that I looked at were done before COVID, and there isn't a lot of research on disengagement with, the virtual option, or telepsychiatry. But what I did find is that many people do prefer in person rather than virtual, and that they didn't feel that was like that being virtual was a reason that they were disengaging. But if they had a preference, I think most people wanted it to be in person. So I don't have much to say about that, but I think that's something we can keep in mind. The other suggestion for change is discussing the discharge plan between the inpatient and outpatient teams, meeting with the outpatient team before the discharge to build that therapeutic relationship, and then offering a community reintegration curriculum. I know we don't have that in Kingston really, but like a partial hospitalization program would increase further engagement. I think another important point is to give the patient opportunity to provide feedback, and that this feedback is actually initiated by the provider and by the service themselves. So if you're providing feedback, and then people can work on certain barriers. Psychoeducation about medication side effects, I think, is a huge thing. So providing psychoeducation to the patient and to the family about what they will expect, and what the risks and benefits are, which I know we do in our practice anyways, but just kind of highlighting that. Motivational interviewing to help with medication adherence. Also, in regards to the medication side effects, trying to use the minimum effective dose, or using an LAI to increase medication adherence, which then will subsequently increase engagement, and allowing easier re-entry into services. So I know, I guess there's differences between different services, but some might be easier to re-enter than others. But I think a lot of patients, might have a initial experience which is negative. They might have had trouble accessing help when they needed it, so making it easier for them to get help that they need as well. So I'm gonna finish off with a quote. So engagement should not be viewed as an event involving an individual's decision to adhere to treatment recommendations, but rather as a process that unfolds in the context of a helping relationship. These are my references, and thank you for listening. Does anyone have any questions or comments?
Thank you very much, Dr. Calic. That was really, really informative. We've got plenty of time for some good discussion, hopefully. I see Dr. Khan's got his hand raised.
Thank you very much. It was very good presentation, Dr. Calic, very much covered in length. One question and one comment. Question is, we were historically always talking about compliance and adherence, and how disengagement is related to compliance and adherence.
Mm-hmm.
And my comment is that historically, again, we were talking about all these factors related to it. When the COVID hit, most of my patients, they went online, virtual, and they were very happy seeing us virtually, because they were sitting in far off places in the remote areas where, unfortunately, when they want to come to the clinic, they have to travel for hours before they were able to see us.
Yeah.
So our patients actually were very happy with the virtual care. So do you come across with any of the literature during your presentation preparation that indicated that those kind of services worked well in engagement, adherence, or compliance? Thank you.
Yeah, no, thank you. So I think in the actual the study that I was looking at, like that I did my research based on, I can't find it now, but I think that patients didn't feel like virtual at that time was not either a facilitator nor a barrier to services. But I think a lot of the research is looking at how to engage people through virtual treatment, because as we know, like even on Zoom, it's hard to engage people. So I think that a lot of the, like, I didn't look too much into the virtual, but like a little bit of what I read is that the studies is how to engage people there. And that I think the preference of most people, like from a few studies I read, was that if they could choose, then they would go in person. Like, and I think the same for the clinician. But of course, if it means that they aren't able to come because of, they're far away, then I would say virtual is better than no engagement. But I think generally speaking, in person will probably render higher engagement than virtual. But I think that's like, that would be the thing. As I was doing this, I was like, oh, I didn't talk about virtual, because everything I had looked at was like before the, before COVID and stuff, or like it was published, in 2022 or whatever. Yeah, 23. Yeah.
Thank you. I think Dr. Yang had a hand up next.
Hey, Masha, I just want to say that was a really great presentation, really clear and beautiful slides and really good analysis. And I think it
Thank
was
you.
very easy for everyone to understand.
Thank you.
My comment is that the suggestions on how to engage people, I think those are things we all should do all the time in every situation, and we're probably aware of. And it's just a reminder to keep doing those things even when we're rushed and don't feel like doing it. My question for you is, the study was for an epi team. Do you think it's applicable in other scenarios as well, with non-epi patients, other patients?
Yeah, I think honestly, I would say I probably think it is. Like if I'm looking at, what we looked at, like homelessness, living with family. So I think, family involvement and living with family, I think that's one that I would say like it's always good to have family involvement. And actually the studies I did, there is one study that talks about engagement in Montreal versus like somewhere in India. And the disengagements are much less in India because family is much more involved. And this was early episode psychosis as well. However, with that being said, I think in general, the more family is involved, whatever time in your life, I think is going to lead to better outcomes. But especially in that younger generation, when they, I think as we spoke about, like they kind of need some sort of parent figure. I would say most of these could apply later down the road, like legal involvement, homelessness, the type of diagnosis, the problem of substance use. I think they would apply elsewhere. It's just, when I looked at this research, because my study was an early psychosis intervention, and then I went and saw how much research there is in other areas, and there really isn't that much because everything kind of goes back to early psychosis intervention. I guess because it's so well structured and there's a lot of research in it, but I would say it probably is applicable, especially some of the barriers that I mentioned later on.
Thank you. Dr. Ray, you've got your hand up for a while. I think you're mute.
Maybe the microphone doesn't work. Go on, he said.
Okay.
Maybe
Maybe you
can
want to type your question in the chat. We'll go on to Dr. Jokic in the meantime.
Okay, thank you, Irina, and thank you, Masha. This was really an excellent presentation. I think this is a topic that is not commonly discussed, and I actually cannot recall that we ever had a topic on disengagement at least in our grand rounds presentations. So very clear and to the point. So when we talk about engagement and disengagement, I really like how you emphasized within your themes the importance of therapeutic relationship. However, we all operate in this imperfect system where often the engagement part has to occur in a specific and often one-time consultation-based model. And I'm just wondering whether you came across any literature on that. Is it possible to achieve engagement in that sort of one-time long consult, knowing that people with mental illnesses, we always emphasize the continuity of care, and that is what is frequently lacking. So how does this sort of balance each other? I know it's a difficult question.
Yeah.
This is something that really crossed my mind when we were talking about this.
I think, yeah, that's a really good question, because I'm thinking like, yeah, a lot of the psychiatrists will see someone on a consultation basis. So then engagement will mean that they're filling their medications and taking their medications, or that they're, I don't know, going to the therapy that is recommended. Like, I guess I'm trying to think like, what would engagement be in that scenario? I can't think of a specific study that looks at that. That would be interesting to look at. So I'm not sure that there was anything that I came across. Like there were studies on like psychotherapy, but psychotherapy is not a one-time thing. I'm sure there's, maybe there's something with like doctors' offices or something like that. I don't know. That's a good question. I think the same thing would probably like apply, like if they have medication side effects, that would be a huge barrier. Or, if they don't believe they have an illness. So I'm not sure how to answer that question. I guess like we can see what they have from this list, like how much of this they might have that then can help us predict if they will disengage or not. But that's a good question, because if there's something we could do in that one-time consult that can increase engagement, that would be very practical. But I'm not sure what the answer to that would be.
Yeah, that is very challenging. And I was thinking more of sort of making sure that the recommendations are followed up with, and then sort of leaving the door open to go back to the referral source or to the consultant if there are any sort of unfinished questions. But that is an important point. Thank you again, Masha.
Thank you. Yeah, I think re-entering, like again, coming, like you said, being re-referred, making that process easier is important too, because not everyone is ready at that point, but then they may be ready down the line.
Thank you.
Thank you.
Thank you. I think Dr. A is going to try and speak again.
Hi, testing. Can you hear me, Masha?
Hi. Oh, yes, I can hear you.
Oh, great. I changed the mic. Thank you very much for that really interesting presentation, and it's thought-provoking. I have a few questions and comments, and it's just meant to provoke thought. Why did you choose to do this study at CAMH and not Kingston? We have an early psychosis program.
I don't know. That's a good question. I'm not sure. To be honest, like I've done research at CAMH a long time ago, and then I think I just wanted to see like what they to go back and do some research there. Like this was all virtual during COVID. It was like in my first year. And I think I wasn't as aware that we had at that time. I wasn't even really aware of Heads Up, to be honest. I think it was like I had my research block early on, and then I was asked Dr. Roberge if she knew anybody, and that's how it sort of happened. But then I think there's a lot of research that could be done here, or that I could have done here for sure.
Well, thank you. And then a few comments and observations. There are some service differences. So for instance, I think the rates of substance misuse you mentioned was close to 50% thereabouts, give or take. I've forgotten the number you gave.
Yeah, for the sample study, for the sample we use, like about 47%, so 50%.
Right. Well, the rates of cannabis use amongst our early psychos program in Kingston is the upper 70s, close to 80%.
Wow. Yep.
And that may have some cognitive effects also that may affect engagement. So that was one point. Another consideration would then be also language. And if there's not a shared language of communication beyond ethnicity and the rest, that may be. And an interesting point, although not from early psychos program, is the huge digital divide and the technology. So when we talk of video conferencing and video capabilities, certainly in the sort of ACT teams, a survey carried out during the pandemic, only 14% of clients actually had video conferencing capability. And for all sorts of reasons, the digital divide was difficult for them. And finally, from a community that does have its own unstable housing population, do you have any recommendations for how to engage people that may have unstable housing or maybe homeless?
I mean, you probably know much more than me working on the ACT team. Well, I think I think like providing appointments in the community, like really, and that's what I know an ACT team does. And like part of engagement and I think ACT teams were made to help with engagement, right? So like when I looked at some of the research, it's like literally from text message reminders all the way to ACT teams. So I think that's the point of that as well, is to decrease the hospitalization rates and relapse rates. So I mean, how to engage the homeless, like I don't know if there's any other good idea other than trying to like find them in the community and go to them rather than waiting for them to come to you. And you know, if they have a cell phone, then communicating more through text or calling them, because I don't know if some of them are going to be using email or anything like that. So yeah, I mean, I think the trick is that, you know, a lot of the homeless people, like I said, come to the emergency or to an inpatient unit. So really, I think ACT is like the only kind of outpatient service that may follow them. So if more services other than ACT can kind of go out into the community or implement like caseworkers, I think everyone should have a caseworker, but that would be great. But I know we don't have funding for that. So
Yeah. Thank you. It wasn't meant to be a catch question. Tree 7 by the Big Boulder was an address I probably got from Dr. Delver, Dr. Fairburn, and Dr. DeJesus. Thank you very much. Thank you.
Okay. Thanks.
Can't see any other hands up at the moment, so I don't know if anyone has got further questions. Maybe just unmute yourselves and speak. And there's no questions in the chat. I think if you don't mind, Masha, I'll just finish off by one question with one question that I have. So I was really interested to see that, you know, you've looked at lots of different factors, and there's something very interesting about the gender gap, that females were more likely to be engaged. And I wondered if, you know, anyone had looked at, you suggested maybe it's because they're more compliant in general. So
yeah, sorry.
no, so I wondered if, because I've also found this in you know, when you're doing research studies, females are more likely to engage than males as participants in any kind of study. So I wondered if maybe that was why, because they had been more likely to even respond to any kind of survey.
Yeah, I mean, so I think the research is that they aren't significantly more likely to disengage. So I think there's a few studies that found that being a male is a risk factor for disengagement, but it hasn't been reproduced. And in our study, it wasn't reproduced. So like in our study, they had equal amounts of disengagement, males and females. But yeah, I mean, I think it's because every disengagement study will look at demographics, obviously, and they'll look at males and females. So that will be one of the factors that they think of. So it's not a well-established finding, but I think it depends on, well, if you're talking about first episode psychosis, which I'm guessing you're not, but like if it's first episode psychosis, I think there's many reasons, because they're at a higher age, they have that protective factor with estrogen, so they may respond better to medications. But I think in general, if it's just looking at any sort of engagement, the study that like talks a lot about males and why they disengage talks a lot about like this masculine role. And I mean, it's not for everybody, not everyone feels like that, but I think it's this role that generally men have a harder time seeking help, because they feel like they have a hard time accepting that they may be vulnerable, that they may be perceived as weak by like even their family members, you know, we don't know how their family is like. So I think might be one of the reasons why males generally have a harder time even coming and engaging. while women are more likely to actually follow the rules that are being said. But there's no like comparison of men and women in general, but like when it comes to first episode psychosis, we have some explanation of as to why males would probably be at higher risk. And they have a lot of the, you know, more homelessness, more substance use, just in general, more of those risk factors than females do.
Okay, that's really great. Thank you so much. This was a really good presentation. Oh, I think Dr.
Can I
got...
Hi,
Oh.
Masha. This is
Hi,
such
Dr.
an
Ari.
excellent topic that you couldn't stop thinking about it, actually. I want to get into the conversation with a couple of points. One is, you know, just to say that, you know, the male-female, the gender differences in engaging with health services. There are some UK studies that men are less likely to approach their primary care provider when they have a symptom than women. They appear late on the scene when the symptom gets a bit too bad. And in my practice, I do cognitive disorders, memory problems, and they never disengage. And the specific reason is, left to their own devices, they'll be a 100% disengagement. In fact, if the patient turned up on his own, that means he doesn't have a memory problem. So the family involvement is crucial there. And I think, just as your study shows, the family support in engaging is vital, is quite important there. We have same observations in our practice.
Like for elderly males and their like spouses and children being involved.
Yeah, elderly, you know, there are no gender problems there. Elderly men and women, they are 100% engagement with the family support.
Yeah, I can see that for sure. I can see that in you know, like because I was just at APA, so there was a talk about borderline personality disorder and like kind of how to manage these patients in emergency settings and things like that, and it talked about like the importance of having like family meetings at the beginning of treatment and like explaining the diagnosis to the family and expectations and trajectory and all of that. And then I realized how, I don't know, but I don't think we do that very often. Sometimes obviously it's because the patient doesn't want the family to be involved, but also I think it's because we don't have the time to do that as well. But that would be great to, you know, I feel like it would prevent sometimes emergency visits and things like that because you're involving the family at the beginning. So I think it is really important to have them there.
Thank you.
Yeah.
Okay, thank you very, very much, everybody, for attending Grand Round today. Hope to see many of you next week. I believe we might be in person next week at PCH. So thank you very much. Have a nice weekend, everybody, and really great job, Masha. Thank you.
Thank you so much. Thanks, everyone, for listening.